All right, let's jump right in. Today, we're calibrating for that elusive 280-plus board score by mastering high-yield pediatric airway emergencies in this explainer. There's absolutely zero room for fluff here. We're going to directly integrate the intricate mechanisms, the discrete management steps, and, honestly, the absolute deadliest diagnostic traps you're going to face on exam day, and more importantly, right there in the emergency department. So picture this. A 4-year-old rolls in with severe respiratory distress. The clock is literally ticking, and the clinical stakes, they couldn't possibly be higher. Your ability to rapidly differentiate these evolving pediatric airway emergencies is exactly what stands between successfully securing an airway and a catastrophic respiratory arrest. It's on you. Okay, Module 1, the subglottic viral swelling, better known as croup. So our primary target here is the parainfluenza virus, specifically types 1, 2, and 3, though, RSV and adenovirus can occasionally be the culprits too. But the essential key to truly understanding croup is isolating the precise anatomical location of the edema. This is strictly a subglottic viral swelling. That narrowing of the subglottic airway is exactly what drives the clinical signature you're actively looking for on the warts. Now, take a look at this AP neck X-ray. This beautifully demonstrates the absolute definitive radiographic marker, the classic steeple sign. See that distinct narrowing? That subglottic constriction correlates perfectly with a harsh, seal-like barking cough and inspiratory stridor. And while this finding is a classic high-yield exam marker, remember it's ultimately a clinical diagnosis. It's heavily based on the actual degree of stridor and the respiratory distress that child is actively exhibiting in front of you. So, what's the absolute medical mandate here? It's all about pharmacologic rescue. How do we properly step up therapy? Well, management strictly requires a single dose of a corticosteroid, typically dexamethasone, to definitively decrease that mucosal edema. But here is the critical exception you absolutely have to remember. If inspiratory stridor is present strictly at rest, you do not wait. You must immediately step up your intervention and add racemic epinephrine aerosols. The alpha-adrenergic effect of the epinephrine rapidly promotes smooth muscle relaxation and shrinks that edema, basically buying you critical time. Moving right along to Module 2, the supraglottic bacterial threat, or epiglottitis. As clinical consultants, you've got to distinguish this from croup in seconds. We are talking entirely about a supraglottic infection involving the epiglottis and aryepiglottic folds. Historically, Haemophilus influenzae type B was the primary pathogen, right? But in today's vaccinated populations, we're actually looking at Streptococcus and Staphylococcus species. The clinical signature here is highly, highly toxic. This child is rapidly decompensating. They're highly febrile, experiencing severe dysphagia, and heavily drooling simply because they cannot swallow their own secretions. And they will strongly prefer the tripod position, sitting straight up, leaning forward, neck hyperextended, just to maximize whatever tiny bit of airway patency they have left. Radiographically, you have to contrast this with our previous subglottic module. You do not order an AP film here. You strictly need a lateral neck X-ray. And when you look at that lateral film, the pathognomonic marker is the thumbprint sign. The swollen epiglottis literally looks like a thumb protruding directly into the airway space, indicating a near-complete supraglottic obstruction. And this brings us to a critical, absolute mandate. Epiglottitis is a terrifying, rapidly progressing emergency. Absolutely zero agitation is permitted. Do not attempt to throat exam in the ER. Do not even think about starting an IV line if it's going to make the child cry, because agitation can precipitate a complete, irreversible airway occlusion. The defining mandate is securing the airway via intubation specifically in the operating room, strictly under controlled anesthesia. Let's put these two side by side. This clinical variance box is basically a cheat sheet for comparing the anatomical obstruction zones and radiographic overlays. Croup is viral, subglottic, presenting with a steeple sign on an AP X-ray. Epiglottitis is bacterial, supraglottic, presenting with a thumbprint sign on a lateral X-ray. Memorize these distinct differences. They are incredibly high yield for rapid, high-stakes differentiation. Next up is Module 3, the superinfection paradox. We're talking about bacterial tracheitis. Bacterial tracheitis is incredibly insidious. Why? Because it's exclusively a secondary bacterial superinfection, most commonly driven by Staphylococcus aureus. The massive paradox here is the timeline. It hits days after a classic viral croup presentation. So the patient seemingly has a totally straightforward viral prodrome, mild fever, a little bit of a barking cough, that completely masks the catastrophic bacterial superinfection brewing right beneath the surface. So how do you actually catch this biphasic decline in real time? You look for the specific clinical marker. The child suddenly becomes toxic and highly febrile. But the absolute definitive key is the racemic failure.
They present with profound stridor that completely fails to improve with racemic epinephrine. Why does it fail? Because the pathology has completely shifted from viral mucosal edema to thick, purulent bacterial secretions and pseudomembranes that physically block the airway, rendering your aerosolized therapies totally ineffective.
When that racemic epi completely fails, you must immediately bypass your standard croup protocols. The medical necessity here strictly demands rigid bronchoscopy and IV antibiotics. You absolutely have to mechanically clear those thick, purulent tracheal membranes and secure the airway via immediate intubation. Let's drill down on this one more time. Both of these present with subglottic stridor. They look so similar initially. The entire diagnostic divergence is based solely on their clinical response to aerosolized epinephrine. Croup improves rapidly, bacterial tracheitis shows absolutely zero response. Keep this front of mind, always.
All right, it's time to put it all together. The master case, testing the nuance. Here's the patient profile blueprint we're working with. We've got a 4-year-old male. Days 1 through 3, he presents to urgent care with a barking cough and mild stridor. He's appropriately given oral dexamethasone for what totally appears to be classic viral croup. However, on day 4, today, he returns to the ER. Now he's toxic, he's lethargic, sporting a high fever of 103.5 degrees Fahrenheit, and he has severe inspiratory stridor.
So, in the ER, he gets racemic epinephrine. And boom, here is the diagnostic trap. The breathing treatment provides absolutely zero improvement in his respiratory distress. This presentation is aggressively designed to tempt you into a misdiagnosis. You might instantly think, well, the croup therapy failed, so this must be epiglottitis. Or maybe you might suspect a severe asthma exacerbation. Let's exhaustively analyze the exact 5 distinct options you're going to be forced to evaluate here. Option A, administering additional oral dexamethasone is a deadly trap. You are dealing with a secondary bacterial infection now, not isolated viral edema. Option B, foreign body removal, totally ignores the clear biphasic infectious timeline. Option C, immediate intubation in the OR for suspected epiglottitis is highly competitive, but remember the prodrome. Epiglottitis strictly does not follow a 3-day viral croup barking cough. Option D, continuous nebulized albuterol is for lower airway reactive disease like asthma, not upper airways subglottic stridor. Which leaves us with the strict absolute mandate management, option E. You must recognize the biphasic illness and racemic failure as the fundamental markers of bacterial tracheitis, mandating immediate intubation and bronchoscopy to clear those thick, purulent membranes.
This entire scenario highlights exactly why high-level medical strategy requires synthesizing the timeline, the clinical presentation, and that crucial pharmacological response. Based on everything we've just covered, when you see a racemic failure following a biphasic timeline, you know exactly how to secure that airway. Trust your clinical variants, stick to the absolute markers, and you will navigate these pediatric emergencies with perfect precision.